Hello everyone. Today we are going to discuss a very important concept in IVF, which is single embryo transfer. We have heard in various media and internet that sometimes the single embryo transfer is better, and so today we will discuss when it is better and when it is not as good. So before we discuss elective single embryo transfer, many of the studies that I'm going to quote today are from Western literature. And we need to understand that uh, there have been studies which show that Indian women seem to age 6 years earlier. So even if we take it as a 3 year time, so the results will vary depending on the age. So for a 35-year-old Caucasian will be equal to a 32-year-old Indian. So this we need to keep in mind. Of course, every clinic like ours, we have data and we are accumulating data, but we are yet to publish it in the journals. So let's start in 2010 when the whole concept of single embryo transfer started. They said that indiscriminate application of elective single embryo transfers in populations with less than optimal prognosis for live birth will result in a significant reduction in effectiveness compared with double embryo transfer. Now, less than optimal effectiveness prognosis means slightly on the older side, multiple cycles. So majority of IVF patients coming to us come quite late actually. Many come around 34, 35, which is actually, you know, quite advanced as far as statistics is concerned, and they do not fall under the optimal prognosis category. Given the high cost of treatment, uptake of elective single embryo transfer would be enhanced by public funding. Now, what it is saying, you have the egg pickup, embryo formation, cleavage stage, blastocyst, and then you put one blastocyst separately. So if you have 10 eggs to start with, if you're very lucky, you will get 3 to 4 blastocysts. And then you transfer one, and then you will get a reasonable pregnancy rate. So that too, if you are young. So that is what it is saying. So are you willing to undergo this multiple embryo transfer and pay for them? So the countries where, like Sweden and other Nordic countries where it has been successful, the main idea of single embryo transfer is to reduce multiple pregnancy rate. And the countries where this has been successful is where it is public funded. Otherwise, the couple will always think, let me optimize my chance in this embryo transfer. Of course, multiple birth, twinning has its risks and complications, but it is a very complex analysis. By reducing this multiple birth complication, are you risking this couple not getting pregnant at all? Is the question. So then came later in 2010 again that patients should be informed of the reduction in both multiple pregnancy rate and overall live birth rate after a single fresh elective single embryo transfer when compared with double embryo transfer in good prognosis patient. In order to maximize cumulative live birth rates following elective single embryo transfer, effective cryopreservation program should be in place. Now that is very important. So not only we are expecting that when you are going to an IVF lab, it is the state of the art with best blastulation rates, means egg, fertilization, cleavage, blastocyst. So at least it has to be 60% or 50%. Not only that, then you have to freeze them separately. Your cryopreservation of freezing and defreezing or thawing these embryos also has to be excellent to be able to give a good chance to your patients. In women aged 36 to 37, which is actually 33 in India, ESET should be considered in good prognosis patients with good quality embryos. In oocyte donor also we can consider ESET. But in others who are, say, in Indian ladies who are more than 35, embryo quality not too good, I don't think ESET is not a good policy. When considering both direct healthcare and societal costs, it should be noted that live birth rate following ESET is significantly less expensive than DET in good prognosis. Therefore, from a cost effectiveness, ESET is indicated in good prognosis patients. So, they are saying if you have twins, then the overall cost to the society is high. So, for the society, for the government, doing elective single embryo is a better option. Now, this is an interesting study in 2011 by Maheshwari et al. In UK, which said why is it that different countries have different uptake of single embryo transfer. And like I mentioned earlier, funding is a very important factor. Like either you have government funding or you have private insurance funding or you pay out of your own pocket. So in countries where you're paying out of your own pocket, uptake of elective single embryo transfer is less. Pressure of both the patients to get pregnant soon and clinicians is high. So let's see. Why do we prefer double embryo transfer? There's a perceived higher success rate. There's a need for undergoing more cycles for achieving similar pregnancy rates. Previous IVF failures, lack of good cryopreservation facility, difficulty in accurate assessment of embryo quality, increased age of female partner. Now, many of our patients are in that age group. Either the age is high or the egg quality is like that of a woman whose age is high. So in these also, if we get a crop of embryos, whether we will take them to blastocyst also is a question. So rather we transfer this small crop of embryos early and in slightly higher number to optimize pregnancy rates. This is one of the debate. Now, reporting of success rates also has a impact. Double embryo transfer, if it is higher, then patients more want. But what are the societal reasons? Desire for twins, desire for quick completions of family, respect for patient autonomy. Now, this has been a very big debate when you want to enforce ESET. If the couple says, no, we want double embryo, we are willing to take the risk of twin, can the clinic or the doctor say no? Okay, that is. Then unavailability of insurance coverage or public funding. Now, why is ESET? Because in good prognosis, ESET has a good result. It completely annuls multiple pregnancy rate. There's a national guidance in some countries. And in some countries, there is funding so that you can do those multiple single embryo transfer to get a good overall pregnancy rate. In 2012, elective set again in younger patients if they have top quality blastocyst. So you should take into consideration elective when you have a embryo quality. What is the prognosis? What is your cryopreservation program? Also, they have talked about cost analysis. Now, there is this group in New York which have said risks of spontaneously and IVF conceived singleton and twin pregnancies differ require reassessment of statistical premises favoring elective single embryo transfer. Now, this is quite a dramatic opinion of this group, which says that IVF twins do better than naturally conceived twins, and IVF singletons do worse than naturally conceived singletons. And anyway, most of your twins are getting delivered at 34, 35 weeks, which is termed preterm, but they're all fine. They do well. So, what is this whole thing about? Yes, there is this small group which deliver very preterm and they have risks and complications. We are not saying no to that. But to prevent that percentage of deform of problems, you are insisting on putting single embryos in certain groups of women who will never get pregnant with that approach. So it's a very difficult dilemma. Serious questions about the rapidly expanding IVF practice of prolonged embryo culture to blastocyst stage followed by ESET. Since it is undisputed that ESET reduces clinical pregnancy chances in IVF when compared to two embryo transfer, proponents of ESET consider such reductions in pregnancy potential appropriately compensated by decreased maternal and especially neonatal risk from avoided twin pregnancy. In absence of increased risk from twin pregnancy, patient would, however, be left with a deficit in pregnancy chances without compensatory benefits of any kind. The concept of ESET therefore requires serious reconsideration unless patients want only one child to complete the family or have medical contraindications to twin pregnancy. In all other cases, ESET as currently increasing considered standard of care actually likely harms pregnancy chances of infertile couples undergoing IVF cycles, therefore unnecessarily prolonging their time to pregnancy and increasing their medical costs. Now, this is something we need to think, that whenever you are discussing or you're offered single embryo transfer, you need to think of few things. Do I fall into that good prognosis category? Does this lab, am I willing to go for multiple embryo transfer? Does this lab have an excellent blastulation rate and cryopreservation program? Then yes, go ahead. You don't want, anyway, not having twins is sometimes is a great thing. But if you fall into the vast majority, low AMH, high age, where we may not even want to do a blastulation and all that, then would you rather transfer slightly higher number of embryos? So this conclusion slightly later, this was which said that it is okay for donor oocyte, PGT, surrogacy, high prognosis patients. You can consider this. The Cochrane review also in 2020 said for young good prognosis patients, live birth rate and clinical pregnancy was lower following single embryo transfer compared to double embryo transfer after single fresh cycle. There was no difference between overall live birth rate and CPR following consecutive single or single cycle of double. Obviously, multiple pregnancy rate was less. So the Cochrane is also saying that single embryo transfer per attempt does reduce your pregnancy rate. So another study says that elderly women more than 40, which actually is more than 35 in India, current evidence is not enough to recommend an appropriate number. So it has to be your judgment. Obviously, it cannot be 4, 5, 6, but 1, 2, 3. Let's see what is the recommendation. This is as late as 2021, where they have said that if your embryos are not euploid or you do not have a favorable factors, for example, you're older, you've had previous failed IVF cycles, yeah, you can go ahead with slightly higher number of embryos, okay? And this is not because you want to burden your couples with multiple pregnancies. No, you want to give your couples that pregnancy for which they are after. So with this, without having an open view and rather just going by the diktats of some presentation somewhere, please look into your particular clinical scenario and then decide. what is the age, what is the AMH, how many cycles have failed, how is the endometrium, so many factors will help you decide. This is a good chart. This is in fertility sterility. So, elective single embryo transfer needs to be implemented very judiciously. It is a very noble concept, single birth, but it has to be judiciously implemented where IVF is not state or privately insured. One needs to know that there is loss of embryos in blast relation, often lower pregnancy rate per transfer, and increased number of attempts when ESET is adopted. Each lab must study its blastoration rate, implantation rate for cleavage, and blastocysts separately, cryopreservation rates, pregnancy rates before deciding its policy. So thank you very much. I hope there is some food for thought. And when you go for your cycle, see whether you fall into the good prognosis or average prognosis or poor prognosis, and then decide how many embryos you would like to transfer. Of course, your doctor would be the best judge along with the embryologist. So trust them and wish you the very best. Thank you.